disasters that have happened in history or poisoning events. But you won't have to really know the details at this point. They're just showcasing kind of, examples of toxicity and the chemistry and the mechanisms involved. Okay, so in terms of principles of toxicity, we're going to be defining toxicity, talking about the history of toxicology. We'll be talking about dose response, which is an absolutely critical topic, which I think is really not really covered for some reason in any other class here at Berkeley that I've at least seen besides NST 11, I guess. But dose response is super critical, both for like regular research, but also for like, prescribing medications or pharmacology or toxicity or anything. It's like a super critical concept that, shockingly, when I see graduate students come in, a lot of them have never even heard of it or don't even know what it is. So we'll talk about dose response and the basics of evaluating safety. Okay, so the definition of toxicology is really the study of adverse effect of chemicals on the living system. So it's basically the flip side of pharmacology. Pharmacology is the study of beneficial effects of chemicals on living systems, right? What we'll talk about in this class is really the mechanism of action and exposure to chemicals as a cause of various acute and chronic illnesses. And really, I think the most critical thing you can take out of this class is recognizing, identifying, and being able to actually really assess the hazards of chemical just by really looking at the structure. Okay? And that's really going to be critical and probably the most important thing you'll take out of this class, which is really rooted on being able to characterize the safety of a molecule and also what's involved with that, and also assessing the absorption, distribution, metabolism, and excretion, ADME. That's a common term that's thrown around in the field, and also its toxicity. And then, for those of you who are not going to stay in the hardcore sciences, I think one of the most important sides if you become a professional toxicologist is the regulatory side, which is absolutely really, really critical these days, right? So developing standards and regulations to protect humans and the environment from adverse effects of chemicals. Okay, so can anyone name some of the agencies involved with this? Maybe one that's not doing a great job right now? Yeah. Yeah, EPA, perfect. Yeah, that was what I was thinking of. The Environmental Protection Agency on a federal level protects us from hazardous pesticides or setting drinking water regulations or air regulations. I don't know if you heard recently, so chlorpyrifos was a major organophosphorus pesticide that I actually studied for most of my undergraduate and graduate career. And it's a really, really widely used pesticide, especially in California, and it's been linked to a whole bunch of really, really toxic effects. I've studied it personally, and it has a ton of off-target effects that could have major consequences for things like memory and development and behavior. And it was scheduled to be banned. It was recommended to be banned, but recently Scott Pruitt, the head of the EPA, actually overturned that and said that it'll be a new day for agrochemical companies moving forward. So that's unfortunate, but there are still local, also state specific chapters of the Environmental Protection Agency, like Cal EPA here in California, which might actually still ban some of those pesticides, which would effectively basically ban it from the country because most of it's used in California. What's another agency for drugs? FDA, yeah, Food and Drug Administration, right? So they regulate all the drugs going through the clinical pipeline and make sure they're safe. Of interest, one type of drug that's not covered in that are nutraceuticals. So nutraceuticals don't necessarily need to go through the FDA. They can just kind of be sold on the market without really testing their safety or even efficacy for that matter. What's another one? There's one more. USDA, Department of Agriculture, which sets safety for various agricultural side of things. Okay, so what are the various branches of toxicology? So there's mechanistic toxicology in terms of cellular, biochemical, and molecular mechanisms through which chemicals can cause toxicity. There's forensic toxicology. So for example, does this show still exist? CSI? Yeah, CSI, those are forensic toxicologists. They figure out the cause of death and the legal aspects of it. Just watch the show when that was the cast from forever ago. There's also clinical toxicology, so these are usually MDs who also have like a DABT degree who treat poisonings and also assess risk involved with occupational exposure to chemicals. There's also environmental toxicology, which talks about environmental pollutants and effects on plants and animals. There's also food toxicologists in terms of looking at adverse effects of processed or natural food components. And then regulatory toxicology, toxicologists who assign risk to substances of commercial importance. Okay. All right, so let's go through a few examples of various, and also the history of toxicology. Since the beginning of time, people have been getting poisoned by various plants and getting stung by, poisonous animals and dying, and also using a lot of these venoms for toxicological purposes, for example, hunting, warfare, and assassination attempts, using animal venoms or plant poisons. There's records in 400 BC, for example, of Hippocrates compiling a list of various poisons and outlining some of the clinical toxicology principles. But it really wasn't until 1493 to 1541 where Paracelsus, who was a physician and philosopher, really, I would say, was the first real toxicologist. And he coined the term dose determines toxicity, which still holds true today, where all substances can be poisons. It just depends on the dose. Okay. So even air, right? If you breathe in too much oxygen, you could die from that. If you drink too much water, you'll cause osmolar stress and increase your blood pressure and cause a heart attack probably, and die from that. Right, so anything can be toxic at a high enough dose. Whether it's so high that you're choking on it and you die from choking on the chemical that you're ingesting or whatever, right? Makes sense? All right, so let's go through a few examples of various toxicological cases. So in 399 BC, Socrates, a Greek philosopher, died of hemlock poisoning. And so the active ingredient in hemlock, which is from this plant right here, it's a natural product called quinine. Okay. So oftentimes people say like, oh, this must be safe because it's like natural. Nature makes a ton of really, really, really dangerous stuff as a defense mechanism to ward off predators or from being eaten. Okay. And so they produce a lot of really, really toxic chemicals, including quinine here, which is an antagonist for the nicotinic acetylcholine receptor. Again, at this stage, you don't really have to know the details of mechanisms or structures or any of this stuff. This is just for curiosity's sake. And antagonizing the nicotinic acetylcholine receptor causes a complete loss of neurotransmission, leading to paralysis, respiratory failure, and death. Okay, that is pretty acute. So the nicotinic acetylcholine receptor is one of those major excitatory neurotransmitter receptors that responds to the excitatory neurotransmitter acetylcholine, and it basically mediates all of memory and motor function, or most of it, in the brain and the peripheral and neuromuscular junctions to mediate both memory and also any kind of movement. So if you antagonize that or inhibit the nicotinic acetylcholine receptor, you will basically completely shut down all nervous system function, and that will lead to paralysis and death. Okay. In 1740, Charles VI, who was, I guess, a Holy Roman Emperor, died from eating death cap mushrooms. This is the what a death cap mushroom looks like. It actually looks like any other mushroom that I see around campus. So probably don't just pick up a mushroom and eat it. But the active ingredient here is alpha-amanitin. This is, again, a natural product that is derived from this death cap mushroom. It's actually a macropolycyclite here. You can see kind of amino acid structures hanging off of this to cyclize it into this natural product. And alpha-amanitin inhibits RNA polymerase. Okay? And RNA polymerase, as probably you all know, is involved in protein synthesis, right? So it inhibits protein synthesis. And that's generally bad, right? If you inhibit all protein synthesis, cells can't survive, right? So they die, and you actually, the actual cause of death and the symptoms from this, from eating alpha-amanitin, is hepatocellular lysis. All your liver cells start dying within probably 12 to 24 hours. Eventually you get liver failure, secondary to kidney failure from all the proteins being released into your bloodstream from the liver dying, clogging up your kidney, and all the toxins build up in your body, leading to a coma, and then eventually respiratory failure and death, which are kind of secondary complications to this initial liver failure. Okay. So, can anyone tell me why, and this will become an important thing later on, or actually probably later today in the course, why hepatocellular lysis? Why not lung death or pancreatic failure or brain death or something as the cause of the initial instigants of toxicity here? Anyone? Okay. No? Yeah.
Because everything goes to the liver first to get toxic.
Yeah, exactly. So under certain situations, that's definitely true, and that's exactly true for this case. So if you eat alpha amanitin, okay, so oral ingestion, alpha amanitin gets into your stomach. In this case, probably goes to your intestines and gets absorbed through your intestinal wall. And if you do that for a compound like this that has a lot of polar groups sticking off of it here, the first place it'll go is through your portal vein, which connects your gut to your liver. Okay, and the first organ really internally beside your gut that alpha amanitin sees is going to be your liver. Okay, and in your liver, it's going to inhibit RNA polymerase before alpha amanitin goes out into other tissues. It eventually will go out into other tissues. But the first tissue that it sees is your liver. So the reason why you die from this is really because of liver failure. It's because alpha amanitin, really the first organ that it sees is your liver, because you're orally ingesting it and then it gets absorbed to your gut and goes to your liver first. And that whole process is called first pass metabolism, and we'll go into very much a lot of detail on that in a little bit. Okay, so if you, for example, snorted a death cap mushroom, right, you would not die from liver failure. Well, this is pretty big, so let's say not snorted it, but if you like, let's say you snorted it, then you wouldn't die of liver failure. Where do you think you would get death from first?
Respiratory?
Someone said it. Yeah, exactly. You'd probably get lung failure first, right? Because the first organ that it would see would be your lungs, and you die from your lung cells lysing open because you just inhibited protein synthesis in your lung. Okay. Does that make sense? All right. Or if you somehow injected it into your brain, you would die from massive brain cell death in lysis and brain death before you got liver failure. Okay. So really, how you absorb a chemical, how you ingest it, or how you're exposed to it really matters in terms of the toxicological symptoms that might occur. Okay, another example. In 1775, Percival Pott found, so he was a scientist, he found that soot was causing scrotal cancer in a lot of chimney sweeps, and it actually turned out afterwards, so one of the policies that he instituted was that these chimney sweeps should clean their hands after they work, and the incidence of scrotal cancer among chimney sweeps plummeted basically to zero after that. So, an instance of a toxicologist back in the 1700s, taking scientific evidence and actually instituting regulatory policies to improve occupational safety. And the reason why people were getting scrotal cancer, I guess these chimney sweeps were rubbing themselves after work. They were being exposed to this polycyclic aromatic hydrocarbon, benzopyrene, okay? And it's not this compound in itself that causes cancer, okay? This actually has to be bioactivated by a whole bunch of enzymes that are existent in various tissues and organs that bioactivate this to an active carcinogen, which ends up covalently and reactively modifying guanine on DNA, interpolating into DNA, and causing DNA mutations, leading eventually to cancer, which we'll spend many, many lectures on later on. So you don't have to remember any of this. We'll be going through this in probably 2 or 3 lectures. But the way this occurs is that benzopyrene will initially get oxidized by cytochrome P450s to form this epoxide here, and then an epoxide hydrolase will open this up into its diol form, and then undergo a secondary oxidation step to form this other epoxide. And so this now carbon becomes highly electrophilic, right, for nucleophilic attack by, for example, the guanine amino group here to form this benzopyrene guanine atom. Okay, and when DNA polymerase comes in to try to replicate the DNA, it won't recognize this as guanine anymore. It'll actually recognize it as cytosine, and instead of replacing the base pair with a C, a cytosine on the opposite end, it'll now replace it with a it'll think that it's a threonine and recognize, or adenosine, and actually replace it with a T instead of a C here. Okay, and then that'll cause a permanent mutation in your DNA and eventually lead to cancer. Now, thankfully, we also have various detoxification mechanisms. So if you, for example, oxidize this on this part of the ring here, or for example, conjugate or detoxify this epoxide with a glutathione to make it highly polar, then these are basically inactive and detoxified. Okay, so these are the kinds of things that we'll be talking about over the next few weeks in terms of how you can be exposed to these kinds of chemicals and then bioactivate them into carcinogens or potentially detoxify them and excrete them. All right, some other examples of toxicological cases. So in 1945, Eva Braun, a longtime companion of Hitler, committed suicide with a cyanide capsule. So this is hydrogen cyanide here. And the reason you die from that is because it is a potent inhibitor of the electron transport chain. It inhibits complex 4 of the electron transport chain, which then inhibits ATP production. And if you inhibit ATP production in the body, the most susceptible organ to ATP depletion is the brain. The brain requires tremendous amounts of ATP on like a millisecond by millisecond basis to propagate neurotransmission. So if you lose ATP all of a sudden, then you will immediately get hypoxia in your brain, loss of ATP, and brain death, as well as the rest of your body dying. So that's the mechanism there, and this is basically a gaseous substance, so it will very easily penetrate into your brain, and you'll die from that. Okay, another example, in 1975, this famous Japanese actor, this kabuki actor, died from eating 4 livers of this pufferfish. Okay, so this pufferfish is the spiky fish that kind of blows up to look bigger, to ward off predators. And in this fish is this natural product called tetrodotoxin. Okay? And tetrodotoxin is actually not found, all over the fish or in the meat of the fish. So we actually still eat pufferfish, right, in sushi restaurants. Hopefully, really good sushi restaurants with good chefs. Because if the chef actually, so most of this toxin is actually located in the liver of the pufferfish. So if the sushi chef, when preparing their pufferfish sashimi, accidentally pokes into the liver and the liver contents spill on the meat of the fish, you will definitely be exposed to tetrodotoxin. And this is an irreversible inhibitor of the voltage-gated sodium channel. Okay? And the voltage-gated sodium channel is one of the really kind of major non-neurotransmitter-based mechanisms of neurotransmission. And if you shut down the voltage-gated sodium channel, again, you'll completely lose all neurotransmission, and then you'll become paralyzed and eventually die from respiratory failure because your diaphragmatic muscles become paralyzed, and then you die. And there's no antidote to this. This is irreversible, so it will never come off. It'll never wash this off. It will irreversibly bind to the voltage-gated sodium channel, close it, and then shut off neurotransmission. Okay. So if you ever go to a sushi restaurant, just make sure that it's a very, very highly trained chef, and you're not getting your pufferfish sushi at a gas station or something. Okay. All right. So another case of more kind of insidious chronic toxicological examples include, for example, with DDT, which was probably one of the first modern insecticides developed, modern synthetic insecticides developed between the 1940s and 1970s. This was attributed, in fact, Paul Mueller, who initially discovered DDT, got the Nobel Prize in medicine for almost eliminating mosquitoes and combating malaria. That actually ended up that resistant populations of mosquitoes started coming up, and it didn't really, they were completely DDT insensitive, so it didn't really work. But nonetheless, there's a lot of success attributed with this in controlling, for example, mosquitoes in Africa, but also insects, pest insects in agriculture. So it was used very, very heavily and widely during the 40s to 70s in agriculture. But the problem was that DDT ended up being an endocrine disruptor. It stimulates the estrogen receptor, can induce cell proliferation, and lead to breast cancer. And the problem with this also was that this is extraordinarily hydrophobic. The log P value of this is on the scale of like 8 to 9. It's extremely water insoluble. So where do you think in our bodies a highly hydrophobic compound might get stored?
Liver.
Anyone?
Liver?
No, liver, it tends to be pretty soluble. Yeah.
Adipose tissue?
Yeah, adipose tissue. Adipose tissue is made up of triglycerides, fat, right, which is inherently super duper hydrophobic, right? So DDT will actually accumulate in your fat. So people that were alive in the 1940s and 1970s still probably have DDT in their fat. And another fatty tissue that was of concern is actually breast tissue, right? Breast tissue is actually very, very fatty, and DDT would accumulate there, and it would actually leach out into breast milk, and so that was also a very, very major concern. Since it's been banned, the levels of DDT have been dropping, but you can still find parts per million levels of DDT in fat from people that were alive back in this time. Okay, so the problem was that because it's so fatty, DDT would actually accumulate and bioconcentrate up the food chain. So, like if bacteria or whatever in the water took in DDT, and then a little fish ate that bacteria, they would accumulate more DDT. And if another fish ate that fish, it would accumulate even more DDT. And if a hawk or an eagle ate that fish, it would accumulate a tremendous amount of, like, orders of magnitude more DDT in the fat of that bird. And it eventually also inhibited the shelling of the eggs and made the eggs super soft, so that when like eagles would nest and sit on their eggs, they'd crack. So it actually also really was a major environmental concern as well. So a famous book was published back in the 1960s by Rachel Carson, Silent Spring, that really described the environmental problems associated with DDT, and it raised a lot of political and public awareness of this pesticide, both as a carcinogen and also as a major environmental contaminant. And eventually, the EPA was formed around this time, and the first thing they really did was ban DDT. Okay. All right, a few other toxicological cases. This one is with metals. Between 1930s and 1960s, this company called Chiso was dumping industrial waste into the Minamata Bay, and it contained a huge amounts of methyl mercury. And methyl mercury is extraordinarily toxic. It'll get absorbed and get into your brain through these transporters. The methionine transporters get actively transported into your brain, react with a whole bunch of proteins and cause non-specific toxicities, and also cause massive developmental problems as well. And so there are about 2,000 victims that suffered severe methyl mercury poisoning, including ataxia and numbness and insanity and muscle weakness and hearing and speech loss, and a lot of birth defects and paralysis, coma, and death. And so this was a major toxicological disaster. Another metal poisoning of note recently was lead poisoning from the Flint, Michigan disaster, where lead was leaching out of the pipes, and it poisoned a lot of people in Flint, Michigan. And so metals can be very toxic. And Wally Wayne will talk about that in his section. Something that I know quite a bit about because my undergrad and grad work was in these organophosphorus agents, are these organophosphorus nerve agents, which have been notoriously used through history, initially developed in World War II, but not really used. But they've since been used in various terrorist attacks, as well as by various dictatorial regimes. So in 1988, Saddam Hussein used sarin on Kurds. This is the structure of sarin. This is a highly reactive electrophile that reacts with serine hydrolase nucleophiles. Particularly, it inhibits this enzyme called acetylcholinesterase. which is an enzyme that breaks down the excitatory neurotransmitter acetylcholine so that it doesn't accumulate in your synapses. And when sarin irreversibly inhibits acetylcholinesterase, you hyperaccumulate the levels of acetylcholine at your synaptic junctions, which then leads to overexcitation of those nicotinic acetylcholine receptors, and that leads to hyperstimulation of those receptors, causing seizures, tremoring, convulsions, excess salivation, tearing, urination, defecation, bronchoconstriction, respiratory failure, and death. This really can happen if you're exposed to enough of this gas. It can really happen within seconds. And in terms of the history, in 1995, terrorists in Japan used this in a Japanese subway station and killed several people from that. And most recently, in 2013 and 2017, Bashar al-Assad in Syria used sarin gas against his own population. And probably many of you saw videos of that. And the people that were kind of like stiff and seizing, those are direct symptoms of sarin. Like if you see a lot of kind of tearing and salivation and tremoring and kind of stiffening of the muscles like that, that's a very, very clear, like if a doctor saw that, they immediately know that that's kind of a sarin type, organophosphorus type chemical exposure. And that's all through inhibiting this one enzyme, acetylcholinesterase. Okay, any questions about that? All right. So obviously these are really, really terrible. Sarin is not the only organophosphorus nerve agent. There's also other ones like VX and taboon that are equally toxic, but probably this one is the most notorious in terms of its usage on people. And unfortunately, this thing is incredibly easy to synthesize as well, and it's a gas at room temperature. So a little bit of that will basically kill everyone in this room within seconds. Okay, so that was a really, really acute toxin. It's a chemical warfare agent. But there have been also kind of more insidious toxicities that have resulted from, for example, drug exposures. One major pharmaceutical toxicological disaster was with this drug called Vioxx. Has anyone heard of Vioxx? No, probably not. It was one? Yeah. So Vioxx was developed as a cyclooxygenase 2 or COX-2 selective inhibitor. And the genesis of the reason for this was because, so you have tons and tons of these COX inhibitors on the shelf in pharmacy stores. So like ibuprofen, acetaminophen, aspirin. They're all dual COX-1, COX-2 inhibitors, which will reduce the levels of these prostaglandins, which are pro-inflammatory, and that can lead to reduction in fever and inflammation. But the problem with these dual COX inhibitors that you can buy off the shelf is that they have a lot of gastrointestinal toxicity, and that's all on target. So it's because you're inhibiting these cyclooxygenases that you're reducing fever and inflammation, but you're also causing GI problems. And so to avoid that, they developed COX-2 selective inhibitors because they thought at the time that COX-1 selective inhibitors, or COX-1 inhibition was really causing all the GI problems. And so Vioxx was really the first drug that was produced as a COX-2 selective inhibitor. It was prescribed to over 20 million people for pain relief for arthritis. It was actually incredibly efficacious. But it turned out that there was a substantial increase in risk for heart attacks. And so it turned out that if you selectively block COX-2, you actually skew the balance of cardioprotective prostaglandins, such as prostacyclins, leading to increase in susceptibility to coronary heart events. And it turned out that 140,000 people could have suffered from serious coronary heart disease or heart attacks from taking this drug. And so it was recalled, and Merck was sued for billions of dollars, and there's still lawsuits about this ongoing today. Another major pharmaceutical disaster was with this drug called thalidomide. How many of you have heard of thalidomide? Oh, wow, all of you. So this was sold, ironically, as a morning sickness drug for pregnant women to alleviate the vomiting and kind of the nausea effects of pregnancy. But it turned out that it was a major teratogen, or some chemical that causes major birth defects. The babies that were born from this had shortened limbs, a symptom known as phycomelia, And there were thousands and thousands of kids that were born with this condition from moms that had taken thalidomide. And at this time, it was not necessary for drugs to be tested for their teratogenic or birth or developmental toxicity-causing effects, which certainly was a really bad idea. But that was the regulation of the time, so you didn't need to test it for potential developmental toxicities. And so it cleared, phase 1 through 3 clinical trials, got onto the market, and unfortunately it was prescribed to pregnant women specifically, and from the 1950s to 60s, more than 10,000 children were born with these shortened limbs. So it turned out that in this case, the therapeutic action of thalidomide was actually through stimulating this inhibitory neurotransmitter receptor called the GABA receptor to cause sedative effects. But it turned out that one of these isomers, S-thalidomide, of this chemical, was a teratogen by actually binding to this protein called cereblon. And actually, this whole kind of biology has shown a huge amount of interest in recent times for kind of drug development purposes, which I'll go into later on in the semester. But nonetheless, S-thalidomide binding to cereblon basically caused degradation, the proteasomal degradation of growth factors like insulin growth factor and fibroblast growth factor, and that ended up reducing angiogenesis, or the stimulation of blood vessels, leading to this shortened limb type phenotype, because basically the limbs weren't getting enough nutrients for them to grow because you inhibited blood vessel formation development. Okay. But interestingly enough, thalidomide and thalidomide analogs like lenalidomide have been since developed by Celgene as massively successful cancer drugs, and they've made billions and billions of dollars off of it. Obviously not prescribing it to pregnant women, but to cancer patients. Does anyone know why it's been so successful as a cancer drug? Yeah.
Because of the blood supply to those cancer cells.
Exactly. One of the hallmarks of cancer is that they'll acquire the ability to actually recruit blood vessels to them, and that's all necessary for cancer and tumor growth so that nutrients can get supplied to the tumor, right? So drugs like thalidomide will cut that off, right? Shut off angiogenesis to the tumor and basically cause it to starve itself because there's no nutrients getting to it, right? So it's been actually an incredibly successful cancer therapy sold by Celgene. Okay, very, very recently, there was also this pharmaceutical disaster with this fatty acid amide hydrolase inhibitor, which is involved in pain, with this drug called BIA 102474, sold by Diol Pharmaceuticals. The first few patients that were treated with this in phase 1 clinical trials basically got severe hemorrhagic brain lesions, and one actually died within 24 hours of brain death. And there were no signs of this in the animal models at all during preclinical testing, but as soon as they got into humans, it killed a bunch of people. And the way this actually works is that it degrades a lipid signaling molecule that binds to cannabinoid receptors. It's the same receptor that marijuana binds to. This whole system is something that I worked on during grad school and my postdoc, so I know this quite well, especially because back when I was a postdoc, I worked with Pfizer to develop a highly selective fatty acid amide hydrolase inhibitor, which is now in phase 3 clinical trials, has been treated in 20 to 30,000 patients without causing any of this stuff, brain death or hemorrhagic, bleeding in the brain. But it turned out that this drug that they sold as a fatty acid amide hydrolase inhibitor did. And we've now since found out that this ends up inhibiting, it definitely inhibits fatty acid amide hydrolase, but it also ends up inhibiting another off-target called neuropathy target esterase, which causes neurodegenerative diseases and hemorrhagic brain lesions and massive inflammation in the brain. And I guess they didn't test for that. So they went, and unfortunately, inhibiting NTE in mice doesn't cause those symptoms, or rats, or even chimpanzees, or dogs for that matter, where they also tested. But it does cause that in humans, and so this is basically what happened, right? So again, these are kind of things that we face. I think in the modern world, we're not necessarily exposed to super highly toxic chemicals that'll kill us right away in our environment, or or in drugs, but you still run into some of these disasters which slip through the cracks because people didn't do their due diligence in terms of making sure that drugs were selected. Right? Okay, so all of that stuff, I would say you don't have to know any of that stuff right now for the exam. This is just more for to get your interest involved, so that you won't fall asleep when we start going into dose response. Okay, so this is where you really need to start paying attention. Okay, you will have probably a question on the exam about some of this stuff. Okay, so as I mentioned, dose really matters, right? So anything at a high enough dose will cause toxicity, as Paracelsus clearly demonstrated. And so how do you determine that, right? Well, it's through doing these dose response experiments. And so from dose response experiments, you can derive a lot of things. You can figure out what the dose or concentration is required to cause toxicity or lethality, or if it's a therapeutic drug, therapeutic efficacy. Okay, and when you're, for example, developing a drug, one of the biggest things, right, is, are you causing therapeutic efficacy at the doses that cause no toxicity, right? Because if you're causing toxicity at a therapeutic dose, right, that's bad, right? Does everyone understand that? Okay, cool. So ideally, right, you wouldn't necessarily want a drug like this, where let's say that this curve A here, so the x-axis here is dose in milligrams per kilogram. So dose is usually expressed as milligrams of the drug per kilogram body weight of the subject. Okay, so for example, a 10 milligram per kilogram dose in a 300 gram mouse would be 0.3 milligrams. Yeah. Or for a 10 milligram per kilogram dose for an average 50 kilogram person would be 500 milligrams, right? Okay, and then on the y-axis here is percent response. Okay, so it goes from 0 to 100, and that response can be anything, like therapeutic response, toxic response, enzyme inhibition response, or like lethal response, right? It's just percent response. Okay. So, and another thing that you should really note here is that the x-axis here is always logarithmic, base 10. Okay. Whereas the y-axis is always linear. So this is 0 to 100 graph. But on the x-axis, on the log base 10 scale, you should never have a 0, right? That makes sense? So, you have so even 10 to the 0, which students have tried to argue with me, equals 0. That's not 0, that's 1, right? I can't tell you how many times I've had to argue with students about that. So for example here, and this can be really kind of any scale, right? Where it's really where your dose response is, but this starts from 0.1, 1, 10, 100, 1,000, 10,000, right? So if you have to draw out one of these dose response curves, you absolutely have to label your axes and make sure that the y-axis is linear and the x-axis is on a log base 10 scale, okay, with no 0. Okay. All right. So if you had a drug like this, right, or let's say the black dots here were your therapeutic dose response curve, right? So let's say A is a drug where A is your therapeutic dose response, and B is your toxic dose response for the same drug. Basically, what that means is that for example, the therapeutic efficacy or the efficacious dose, ED50, the 50% concentration at which you get 50% therapeutic response is in this case 10 milligrams per kilogram, right? But at 10 milligrams per kilogram, or 50% of your population is getting a therapeutic response, you're already getting 20% toxicity from that, right? That's not great, right, for a drug. And by the time 100% of your people are getting therapeutic response, in this case, if the light triangles here are a toxic dose curve, in this case, you're getting 80% toxicity happening in your patients, right, when you're getting 100% efficacy from your drug. So if you have a dose response curve like this for a drug, that would be terrible, right? That basically means there's no therapeutic index here. There's no safety margin for your drug. Does that make sense? Okay. So values that you can derive out of this, and values that oftentimes are reported for any drug, reported to the FDA, or a pesticide being reported to the EPA, you need to both understand the effective dose, the ED50. So again, that's the dose at which 50%, you get 50% efficacy. Okay, the dose at which you get 50% efficacy is the ED50. And also the toxicity dose. So this is any kind of toxicity, whether it's, I don't know, getting cancer or getting a headache or vomiting or whatever toxic response, right? Which could also include death technically, is basically the TD50, or the dose at which 50% of your population gets toxicity. And then you also have to know your LD50, right? At what dose do you end up killing 50% of your population? You obviously don't want to be anywhere near that dose response curve for LD50, right? Does that make sense? Any questions about that? Okay, another thing you can get out of these dose response curves, so these are basically like, treating like a mouse or a rat or a human with a drug in vivo, right? In a living organism, where your dose is in terms of milligrams per kilogram, right? But you could also do this for example, kinetics of enzymes or binding of chemicals to protein targets like receptors, or for shutting down ion channels or whatever, figuring out the 50% concentration at which the chemical will bind to a specific protein. And for that, you can express that in concentration, or IC50, so the 50%, or the concentration at which you inhibit 50% of your enzyme or receptor or whatever protein target that you're binding to. So that's not necessarily an in vivo dose response like with this milligram per kilogram. That's actually in a test tube with like pure protein and your chemical, and figuring out what concentration of the chemical will bind to your protein. And from that you can get information like IC50. Now in the case of concentration, you wouldn't necessarily express that in milligrams per kilogram, you would express that in molarity. So for example, you'd say micromolar or nanomolar or molar, right? Which is mole per liter. Does that make sense? Okay. You can also have different types of dose response curves. So I would say for most drugs, it would look something like this, where you have this logarithmic dose response curve, where you have no response up to 100% response at some dose, right? But for beneficial things like nutrients or vitamins or things like water, right? You could have hormetic dose response curves where you have this U-shaped curve where some deficiency of that nutrient is very bad; it causes death. But there's some kind of optimal region, which is good. It doesn't cause any toxicity. But then at too much of it, it causes death again for toxicity, right? And you can probably think of a lot of examples like this. So vitamin A, for example, if you don't have any vitamin A, you'll die, right? You need some kind of okay level of vitamin A. But if you are gorging vitamin A and eating way too much of it, and it's precipitating in your kidney and it's causing kidney failure, then that would cause toxicity, right? You can say the same thing for water. If you don't drink any water, you're dead. If you drink an okay amount of water, you're okay. And then if you are drowning in water, you'll die, right? So U-shaped curves. You won't really have to use those, at least in any kind of toxicity study. Okay, so how do you then compare these dose-response relationships, right? And I mentioned this already earlier, but so for any kind of drug or pesticide or whatever, you're going to have these kinds of curves, right? So you'll have an effective dose curve. Hopefully that will be to the left of your toxic dose response curve, which will hopefully be to the left of your lethal dose response curve, right? If your effective dose response curve is to the right of your toxic or lethal dose response curve, is that good or bad?
Terrible.
That's bad, right? And why is it bad?
Kill you before it does anything.
Yeah, you're dead before you get effective pharmacological response, right? That's not good for a drug. I've also had to argue with students about this ad infinitum in previous years, so I just want to make it clear that your effective dose response curve should be to the left, because you're getting pharmacologically, therapeutically effective response at a lower dose than you're getting death, right? Okay, so just to make that clear. So again, the terms are ED, effective dose, TD, toxic dose, LD, lethal dose, and you know, TD and LD, these aren't mutually exclusive. So lethality can be included in toxicity, but not all toxicity is obviously lethal, right? So toxic dose doesn't necessarily have to correspond to lethality. There's also some other terms that are important that get thrown around in regulations, such as the no observable adverse effect level, which is the highest dose at which there is no statistically significant adverse effect. Okay. These are kind of like terminology things, but and then there's the lowest observable adverse effect level, and that is the lowest dose at which you have a statistically significant adverse effect. So the LOAEL is always going to be higher than the NOAEL. Okay. So once again, the NOAEL, I'm not really going to test you on this, but if you ever want to be a professional pharmacologist or toxicologist, you have to know these terms. NOAEL is the highest dose at which you don't see a statistically significant adverse effect. Okay. So it's basically the highest dose at which you don't really see a toxic effect. That's statistically significant. Okay. Yeah.
Is it along the lethal dose curve or the toxic?
Oh no, in this case, adverse effect would mean toxic. So like any adverse effect, whether it's like a little migraine or something. Yeah. And then LOAEL is really the lowest dose at which you actually see a statistically significant adverse effect. Okay, so that's the first kind of lowest dose where that significant effect would be like a 1% adverse effect that's statistically significant, but that still would count as the LOAEL dose. Okay. All right, so in this case, if I say like calculate the ED50 versus TD50 versus LD50, right? Your ED50, or the dose at which you get 50% effective response, in this case, you draw a line across 50% and go down, that would be 1 milligram per kilogram, right? The toxic 50 dose, the TD50, would be 10 milligram per kilogram, and the LD50 dose would be 100 milligram per kilogram. Any questions about that? Easy stuff, right? Okay. All right, so why does all this stuff matter? So for any drug, you have to report the therapeutic index, okay? And this is absolutely critical. This really, determines, and the FDA will look at that and say your therapeutic index is not good enough, right? And meaning that your drug is not safe enough. It's causing too much adverse effect at doses which are getting therapeutic effect. Or that your therapeutic dose response curve is not separated enough from your toxic dose response curve. Okay. And so what is the therapeutic index? It's the ratio between the LD50 or the TD50, very likely the TD50 versus the ED50. Okay. You still basically have to report both. So the LD50 versus ED50, or the TD50 versus ED50. Now, how many of you think that your therapeutic index should be 1 or less than 1? How many of you think therapeutic index for a drug should be like 10 to infinite? Okay, so if your TD50 versus ED50 were less, or if it were 1 or less than 1, what would that mean? That would mean that you're getting toxicity before you're getting effectiveness, right? If your TD50 versus ED50 were like 10,000, right, that would mean that there's like multiple orders of magnitude dose difference between your toxic dose versus your effective dose, right? So you want this number to be as large as possible. Like a 1 number is definitely not acceptable. Probably even like 10 is not acceptable. Like maybe 100, 1,000, right, would be acceptable for a drug, right? Does that make sense? So the greater the TI, the therapeutic index, the greater the relative safety. Okay. Any questions about that? Okay. All right, so let's say you have drug A and drug B. Okay, so just by looking at those curves, without calculating the TI at all, which one of you think that A is safer? Okay, which one of you think B is safer? Okay, yeah, good. Right, so just looking at this, right, it's pretty obvious that, this is not good, right? So basically, by the time you're getting 100% efficacy, you have like 50% like toxicity, right? That's not good. Whereas here, at 100% efficacy, you have 0% toxicity. That's what you want, right? Okay, so if you want to calculate the therapeutic index here, basically you take the TD50 for A, which would be 100 versus ED50, which is 0.01. That'll give you a 10,000 therapeutic efficacy. That's pretty good. Drug B, on the other hand, has a therapeutic index of 100, which is probably not good enough. Okay, but dose response curves don't always look like model dose response curves where every single dot is like on this kind of simulated logarithmic line. Sometimes you get kind of broader dose response curves. And if you just did the therapeutic index, for example, in this case for drug A versus B, in this case, the LD50 for A and B are identical. Okay, and the ED50 for A and B are identical. So you would think that these are both equally safe, right, or equally toxic. But just looking at this, how many of you think that B is safer? Okay, a few hands. How many of you think A is safer? Right. So basically, this is showing you that when you're getting like 30% efficacy of your drug, 20% of your people are dead, right? That's not good, right? Whereas with drug A, 0% of your population are dead, right? Does that make sense? So in general, you don't want any death at an efficacious dose. Okay. And the reason why the TIs, the therapeutic indexes, are the same here is that the LD50 and the ED50s are identical for drug A and B, but clearly drug B is less safe, right? You're getting death before you even get any effective response. So here, like at 0.01 milligram per kilogram, you have 10% of your patients dead before you get any therapeutic efficacy. That's not good, right? So there's also the margin of safety that you have to report, okay? And that is LD1 divided by ED99. Okay, so LD1, which would be like all the way down here, right, for drug B, drug B, but for drug A, the LD1 is like all the way over here, right? So in this case, the margin of safety for drug A is 1, which is terrible, which is, I guess still not that great, but drug B would be 0.0002, which is clearly unacceptable, right? That means you're dying before you're getting efficacy. Does that make sense? So you have to report therapeutic index and margin of safety in case the slopes of your dose response curves aren't, perfect curves. Any questions about that? Okay, so just comparing toxicities of various agents, dose really matters. So, ethyl alcohol, I'm sure this is something that's abused heavily here, but that has a very, very high LD50, right? So you can take a lot of alcohol and not die from it. So the LD50 here is 10,000 milligrams per kilogram. Sodium chloride, you can die from that, but not until very, very high doses of 4,000 milligrams per kilogram. Antioxidants like BHA or BHT, 2,000 milligrams per kilogram. Morphine, which is highly addictive, but in terms of lethality, you have to take quite a bit of it to die from it, 900 milligrams per kilogram. Caffeine, about 200 milligrams per kilogram. So, caffeine for a 50 kilogram person, that would be about like 10,000, so like 10 grams of caffeine, right? That's quite a bit. Nicotine is quite a bit more toxic. It's 1 milligram per kilogram. So, for a 50 kilogram person, 50 milligrams will kill you. Curare, which is now getting into like natural products that are derived from various plants and organisms, that's getting down into 0.5 milligram per kilogram. Shellfish toxin, 0.01 milligram per kilogram. Sarin, the chemical warfare agent, that's now into the microgram per kilogram range. That's extremely toxic. And botulinum toxin, which is probably one of the most toxic substances in the world, that's actually from a naturally derived toxin, is on the, what's that, 0.01 microgram per kilogram. So extremely toxic. That's also the stuff that some people, inject into their skin for getting rid of wrinkles. Does anyone know why you don't die from botulinum toxin? Skin therapy?
Not in your bloodstream.
Yes, it's not in your bloodstream. Okay. If this actually got into your bloodstream, you would die very, very quickly at a very, very low dose. But there are basically practically very little capillaries right underneath your skin where you inject BT, and so it'll basically paralyze just that area of the muscle without actually getting into your systemic bloodstream and kill you. So if it gets into your nervous system or into your muscles through your systemic circulation, botulinum toxin will immediately kill you. Okay. Any questions about that? Okay, a little bit behind. I want to get through just at least a few slides in the absorption distribution section, at least introduce you to the concepts. Trying to get through the driest parts of the class as fast as possible so that we're getting into the more interesting areas, hopefully later next week. Okay, so we talked about dose response, but now for the next many, many lectures, we're really going to be talking about how chemicals are absorbed, right? How you're taking in the chemical, how it's actually absorbed into your body, how that chemical gets into systemic circulation, your blood circulation, how it then gets distributed to all the different tissues, and then how you metabolize it and then excrete it into urine or feces or sweat or expired air. Okay. So there are a lot of factors here that I want to introduce you to. So when you're exposed to a chemical, you have to first of all absorb it, right? That means get it into your body. And primarily, how it gets into systemic circulation or to your organs. Once it gets absorbed, depending on the physical chemical properties of your molecule, whether it's highly hydrophilic and water soluble, or whether it's highly hydrophobic and not water soluble, if it's not water soluble, it has to, be soluble in your bloodstream for it to be able to be distributed, right? So for non-soluble chemicals, they have to bind to proteins to keep it soluble. Okay? Otherwise, you wouldn't really be able to absorb it. So once it absorbs, depending on the properties of your molecule, it'll probably bind to some kind of binding protein to keep it soluble, and then it'll get distributed throughout your bloodstream and to your organs. And once it gets distributed, it can be metabolized, right, for excretion, or it can be metabolized to cause toxicity, or it can be stored. So, for example, in the case of DDT, which is extremely hydrophobic, right, it can be stored in your fat, or if it's a drug, it could go to the site of therapeutic action, right? So if it's an anti-cancer drug, you'd want it to be distributed to the tumor and not end up all in your fat, right, or your liver. Does that make sense? Unless you have liver cancer. So how a molecule is distributed, and then where it's stored, what is its free concentration, how much of it is getting to your therapeutic site of action versus some storage site, or how much of it is getting metabolized and being excreted versus how much of it is actually getting to the site of therapeutic action. All of this stuff is absolutely critical, right? Because a lot of times, it's quite challenging to get, for example, drugs into the brain for an Alzheimer's therapeutic because the brain will export a lot of chemicals out, or if it's an anti-cancer drug, cancers have all these transporters that they express that will basically, export out any drug that it sees and make them very, very chemotherapy resistant. So, distribution of your molecule to the therapeutic site of action versus all of these other competing sites is really, really critical. Okay, so let's talk about absorption first. So what is involved in absorption? So again, really the properties of your chemical really, really matter here. Is it hydrophobic? Is it hydrophilic? Right? What's the log P of your molecule? Is it like -5 or is it like 12? or is it somewhere in between, like most drugs, around like 1 to 2? Is it ionized? Is it positively charged or negatively charged? If it's charged, it's very likely not going to be able to cross a lipid bilayer of a cell membrane, right? Because the cell membrane is extremely hydrophobic. Whereas if it's not ionized, it could probably just diffuse across the cell membrane, right? Is it a weak acid or is it a weak base? What's the molecular weight? Is your molecular weight like 1,500 Dalton? That would be massive, right? That's almost like a protein. That would have a very hard time diffusing compared to a tiny molecule that has a molecular weight of like 300, right? Is it volatile? So if it's a gas, you'll probably inhale it versus taking it orally, right? And that gets us to route of exposure. How are you being administered the drug, right? So a lot of drugs are not orally bioavailable. So for example, if you take Herceptin, which is a breast cancer therapeutic against the receptor HER2, that is an antibody. That's a gigantic protein, right? You can't orally ingest that. Your gut will, all the proteases in your gut will tear that apart, and none of that antibody will be left, right? So in that case, you have to inject it through an IV injection, right? Intravenous injection directly into your bloodstream. Versus aspirin, which you could just take as a pill. It'll get into your stomach, it'll get non-ionized, it'll get protonated and non-ionized and get easily absorbed to your stomach and under acidic pH. Does it, get across cell membranes, right? And again, that depends on whether it's ionized or non-ionized, but the pH of the local environment. And also, so will it just passively diffuse, or do you need some kind of transporter to take it down a transport gradient, or do you actually need some kind of ATP-dependent transporter, protein transporter on the membrane surface to carry your drug in, right? So these are all really, really critical things that you need to know for absorption. And then this is just a summary slide of basically what we'll be talking about over the next several lectures. So this is a good place to end. But essentially, what really it boils down to, at least for toxicity, is do things go through first pass metabolism? So someone mentioned it earlier. When you are exposed to a chemical, does it get to your liver first? And the reason why that matters is that the liver is the major detoxification site for any chemical, okay, whether it's environmental or pharmaceutical. And so if it goes through first pass metabolism through the portal vein, it'll get to your liver first, and you'll probably detoxify it before it causes any damage. If it gets into systemic circulation directly, that could cause direct toxicity and have a much higher susceptibility for causing toxicity versus whether a chemical was able to see your liver. And depending on how you take in your drug, whether it's through ingestion, inhalation, intravenous injection, intraperitoneal injection, subcutaneous, intramuscular, dermal, it really depends how fast the chemical will get into your systemic circulation or how much of it will get into first pass metabolism. Okay. So I'll finish there and we'll pick up next Tuesday.